as Dr. Cooper says, it worked until it didn't. If I ever lost weight before, it always came back. And within this 12-year period, this weight has not come back. And that, to me, that's the miracle, not the losing weight part. I could do that so many times. It's the fact that it didn't come back. And I can't even put into words how amazing that is, that it didn't come back.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so good to see you two.
Hello.
You too.
All right, on the show this week, metabolic meds. What? Again?
Woohoo!
We've decided, I think you said this is our fourth episode, Dr. Cooper, of talking about metabolic meds, but
this is the
we
fourth
thought
one.
the fourth one, we should revisit because there is a lot of misinformation going around about these meds and how you use them and where you should get them. And so we thought we would just dive in again. And I wanted to kick things off with an email from one of you, one of our loyal listeners, Marissa. Thank you so much for this email. She says, "Hi, Mark. Thanks for making Fat Science. It's been super helpful. Would you all please make an episode with tips for maximizing the benefits of GLP-1 medications? I know specific recommendations have come from a doctor who knows my personal medical history, but I'd love to hear what general tips Dr. Cooper has, and also tips from you and Andrea as experienced users of the meds. There's a lot of what I consider bad advice out there, like that we should restrict our calories as much as possible to lose as much weight as fast as possible." So that was a question from Marissa. Thank you so much. Dr. Cooper, let's start out. These GLP-1 drugs, before we hit record, I think Andrea was talking about, we've been on these meds for 10 years, a dozen years. They're not new, but they feel new. So why don't you address that part first, Dr. Cooper?
Okay. And thanks, Marissa. That question just hit so many important points that we can discuss and things that I hear quite a bit too. So I'm excited to talk about those. But the metabolic medications that we're hearing about today are in a category of meds for the most part called GLP-1 medications. And there's also a dual agonist, which is GLP-1/GIP, two different hormones. And the idea is that these medicines mimic our body's hormones that are called GLP-1 or GLP-1 and GIP. And it's true, they first started coming out back about 10 years ago, almost 10 years ago. And that's kind of the beginning introduction to this family of medications that we've had. And scientists have been working on medications in this category probably since the 1980s. So it's just long term that we've known that these hormones help regulate our metabolism and kind of normalize our metabolic function throughout the body. And so nowadays, they've just gotten so much attention, I think because it finally crossed a tipping point where people started finding out about it, where it was just for many years, nobody was really paying attention and nobody wanted to talk about it. There was just all of the shaming to people with high body weight that they should just solve the problem with their diets and their exercise, that it almost put blinders on people to where they just didn't even want to know about this group of medications. And then suddenly there's been a tipping point and it's now kind of known throughout the world in popular culture. So
Dr. Cooper, do you think part of it is that these drugs are now being legally prescribed for weight loss? because they were first designed for what?
Well, they were first designed for diabetes, and that is true. And so they first came out for diabetes, and it was seen during the diabetes trials, and patients receiving these medications for diabetes were found to have this significant weight response as well. And so shortly after they came out for diabetes, the clinical trials started taking place for obesity as well. And so the indications for obesity started coming through. And some of that was quite a long time ago, actually. And it started with the medication called Saxenda, which is the counterpart to another medicine called Victoza. So Victoza was the marketed medication for diabetes, and the identical medication was rebranded under the name Saxenda and marketed for obesity at a higher dose. And so they set the stage for how these medications were going to jump that chasm to be prescribed for obesity alone. And so then other medications followed suit, and they took that same model. So there was Ozempic, which came out for diabetes. And then shortly after that, it was released under a different name, the same identical medication called Wegovy, marketed for high body weight. But I think the knowledge has been there for a long time that they have a significant impact for other types of metabolic dysfunction, not just diabetes, not just obesity even. And I think practitioners who have used these medications over the years have actually seen the benefits in many different areas of this class of medications.
But so many people are told by their doctors and their healthcare professionals that in addition to taking these drugs, they should restrict calories. When I know that during the course of my using some of these drugs, I've actually had to eat more often, and not necessarily bigger meals, but eat more often to keep up with making sure that I get enough nutrition. So sometimes, because of the way that these drugs make you feel fuller, your brain is sort of thinking, oh, I'm fine, I'm satisfied, I'm good. But you actually need to really make sure that you're eating properly.
You do. And this is something that it's really interesting because it's just like with diets. If you think with diets, they can force your body to lose weight in the short term. But then once your body figures out what you're doing, it will slow your metabolism and it will, promote that weight regain rapidly by this mechanism called biological adaptation that influences all your hormones that regulate metabolism. Well, just as you can't trick your body with diets, you can't trick your body either with medications. I mean, these medications are sophisticated and powerful, but they can't really outsmart our own brain. Our brain is more sophisticated and powerful than these medications are. And in terms of our brain neuroendocrine function, it's more dialed in. And so it's dialed in to protect us from famine. And so with our patient base, we've made an effort to not permit or recommend any type of dietary deprivation type of plan. And instead, as you said, Andrea, it's more that we need to implement this mechanical eating because one of the side effects of the meds is to hamper the hamper the appetite, one of the side effects.
Right.
And so I see that as not a mechanism of its effect, of its beneficial effect. I see that as a side effect that's sometimes not wanted, actually, because it can be too powerfully inhibiting somebody's appetite to the point where they may not get enough nutrition. So then we implement this mechanical eating plan where within an hour of waking, you get your breakfast, all the food groups, then you eat meals 3 times a day, balanced meals, and in between snacks you eat in order to prevent more than 3 hours of gap in eating throughout the day. That's kind of what I've recommended all along. And there's lots of reasons why I came to that, which we could talk about. But the reason is we don't want to allow the metabolic adaptation forces to kick in the body and fight the effect of the medication. So that's kind of what our philosophy is. And I know a lot of people have different ways of doing this or thinking of these meds, but if you learn about how the metabolism works and you really understand it, it becomes pretty obvious that we should not be prescribing these meds in conjunction with a restrictive diet.
Well, do you think that sometimes a lot of these people are using them for a short term, like they're using them as a diet, to use them to restrict eating? And I think that that's sometimes what happens.
Unfortunately, I think they are being used that way. So the drug companies and the insurance companies, they use language like this medicine is to be used in conjunction with a calorie restricted diet.
Yes.
Right. And when you look at the FDA, what the FDA originally approved in the language for these medications was that they should be used with nutrition guidance. It had nothing to do with calorie restriction from the FDA. It just said nutrition guidance. And so that I tried to point out years ago when these meds first came out, is tried to point that out to the pharmaceutical industry, that they were going around saying they're supposed to be used with this low calorie diet when the FDA, and they would say they had to because the FDA forced them to say that. And I would show them, no, the FDA is saying to use a different language, which is nutrition, not low calorie diet. But they never changed. And then the insurance companies come back and say they won't authorize it if you're not saying the patient is following a low calorie diet. Now, Our clinic doesn't prescribe low calorie diets. So we write back to the insurance and say the patient is on a medically supervised nutrition plan. And it's basically the medically supervised part is to eat mechanically all the food groups throughout the day, try to avoid the chemical additives, keep yourself fueled. It's much more focused on being fueled, not restrictive. And so we usually get the prescriptions through, just saying that. Every once in a while, they'll come back and say, you didn't say low calorie. It's like, but it's faulty thinking, because if you think that this medicine is going to normalize somebody's appetite, well, if they were in a mode of not sensing their food supply, and so it ended up making them feel like they were satisfied with less food at a time, why would you then put them on a low calorie diet? I mean, it makes no sense. So, but a lot of our patients end up eating more because of our, enforcement of this nutrition strategy. They end up eating more than they did before when they were trying to starve themselves for periods of time and keep themselves on these very low calorie diets, and then end up with this metabolic adaptation and get discouraged and then go back and forth into that weight cycling mode. So they're much more, as you said, Andrea, much more consistently fueling and on these medications and doing fine, doing great. In fact, the drug company information, one last bit, is that the drug company studies showed this. They showed that if they put the patients on a diet first to try to restrict their calories to force them to lose a certain amount of weight before they started the medication, those patients, the medication stopped working sooner than if they didn't do that. And they started regaining weight while on the medication sooner than if they hadn't gone on that diet before they started. So I tried to point that out to them too. And it's just a disconnect, unfortunately, in our society.
Right.
Yeah. So big red flag. If your provider says, here, take this GLP-1 and, oh, by the way, stop eating as much. Huge
Big
red flag. Andrea, I'd love to, Marissa also asked what our experience had been as users of these meds. I remember taking Victoza back in the day. And I think one of the big things that I had to adjust to is that these drugs make my appetite not nearly as intense. Like I never, ever feel really hungry.
No.
It's just sort of, I feel kind of full a lot of the time. And so, like Dr. Cooper said, I've had to, just schedule out my eating and just make sure that I eat. Andrea,
I
what's your experience been?
I would agree with that. And then there's also something that is called food noise. It doesn't get rid of, I mean, I am a so-called what they call foodie. I love food. I always am thinking about food and, what restaurant am I going to go to? Where's my next meal? I finish lunch and I'm like, where are we having dinner? But in terms of like obsessive food thought, which I probably had before, and I was never like a hoarder or an overeater type of person. I never was like that type of eater, but I did eat a lot more quantity than I eat now. I don't do that anymore. And I don't obsess about food. I don't have that anymore. It doesn't come into my brain. That is gone. And that is definitely the drug. And I would say the other thing is because it does slow down like how you eat. The scientific terms, that's a Dr. Cooper thing. But I would say in the Andrea way of talking about it, it slows down how you eat and there's sort of a delay to it. You have to sort of adjust like when you're eating. And I have a friend who's also on the Manjaro is what I take now. And we talk about like going over the line. You have to be like really careful when you're eating because if you eat too much, the nausea will kick right in and fast.
Hmm.
And you could either throw up or just get really nauseous and need to lie down. That does happen. And for my friend and I, it is not enough to say, oh my God, I can't take this drug anymore because the benefits are so unbelievably amazing. But for some people, it could be too much. And some people, I have some people I know who, when they first started on the drug or when they up their dosage, the nausea is too much for them. But I've never had that kind of nausea that, I feel nauseous the whole time. I've never had that. I just have that thing of like, and seriously, I know it's crazy. It could be as little as just like one Thin Mint type of thing, like a Monty Python thing. Like that could set me off. And it's like, uh-oh, uh-oh, uh-oh. But, to me, it's like, it's a hazard of the thing and it's not a problem. And I know other people who, when they're upping their dose, have had episodes of low blood pressure, but they work with doctors and the doctor thinks it's actually because they have lost weight. They think it's probably low blood pressure because they've lost a lot of weight.
That's
So,
interesting. Yeah. I sure noticed that too, Andrea, that, I noticed that portion sizes in most restaurants are actually pretty big. And
yeah,
whenever I go out to dinner with my wife now, I usually can only eat about half the entree and ask
yeah.
for the other half to be put in a to-go box. Dr. Cooper, how do these GLP-1 drugs make you feel full like that? Because these hormones are created in the stomach mostly, right?
They're in the GI tract. But one thing we have to keep in mind is just like weight, excess weight is a symptom of metabolic dysfunction. Irregular abnormal appetite is also a symptom of metabolic dysfunction.
Mm-hmm.
So these changes to your appetite, instead of thinking of these meds, we don't like to think of them as appetite suppressants, even though they might suppress your appetite, but they're getting to the root of metabolic dysfunction. And so by doing that, your appetite receptors in your brain are getting a much clearer picture of what you're eating and than it did before. And so it's almost like it's illuminating that part of your brain that sees the food. And so that's the way to think of them. But they are taking after our natural hormones that are produced in our gut that kick in when we eat, that send a signal to our brain and the rest of our body that we've eaten. And the brain can actually see the food that we've eaten better because of these hormones, like the content of it. It can figure out what it is and the caloric value and the composition and all of that. And so it it really influences that. And then through that brain pathway, it triggers the chemical reactions that help produce hormones that activate receptors that regulate our weight set point and our satiety, and then send signals back and influence our insulin levels and all of that. So same thing with what you were saying, Andrea, the blood pressure is also a symptom of metabolic dysfunction, elevated blood pressure, hypertension. Remember, we talked about metabolic syndrome, which is high risk metabolic dysfunction because it presents as elevated blood pressure, elevated cholesterol, sometimes fatty liver, insulin resistance, maybe with diabetes or prediabetes. So these medications, because they're improving our metabolic function, they're reducing all those symptoms that go with metabolic dysfunction. So it could be reducing the elevated blood pressure, normalizing the appetite, or influencing how your brain sees the food, reducing the body weight through various mechanisms of how we partition energy in our body. And so it's good to kind of look at the whole picture when you're thinking about these meds,
Right.
rather than see them as they've been labeled weight loss med or appetite suppressant. But the way that they do it is more of our weight regulation, our appetite regulation often is really based on the influence of two different buckets of signals. One that would broadcast throughout the body, we're starving, there's a famine. And then there's a whole separate bucket that would be broadcasting, no, we're not. We have enough food, we weigh enough. So they're two opposing forces. And when you add the GLP-1 med or the GLP-1 GIP med, it's adding to the bucket that says we have enough food supply. So it's increasing the voice of those types of signals in the body. And that influences whether our metabolism is in a state of red light, put on the brakes with the metabolism, or green light, go ahead and spend energy. We're not worried that you're going to run out of fuel. All of this is influenced by this. And so it's a very nice way of tipping that balance for a patient that's really tipped the wrong direction with those buckets. It helps restore more of a normal balance.
Right. And my metabolism was so broken and messed up. I also had a gastric sleeve done. I should add that too. But
Right.
now I have no fatty liver. I have no diabetes. My numbers have been about a 5.3 for years. And what else do I have? No high blood pressure.
Right.
I have
Cholesterol, much better.
Yeah.
Mm-hmm.
Total. Yeah. Most of
Yeah.
that's pretty low.
All of the metabolic
or
syndrome.
low or high, whatever that
Mhm.
thing is. But I mean, it's still doesn't want to let go of that last bunch of fat on my butt. But it is amazing. I mean,
And
like
when
150 pounds of it is
Right.
gone, but
Right.
there's still some to go. But it is pretty amazing. I mean, it wouldn't have
Yeah.
happened without all this.
Well, and when you were talking about the nausea, Andrea, that is good that you mentioned about you also had that surgery. So
Yeah.
So
So I do have less capacity. I would also say, the other thing I wanted to mention was when we eat, people always forget that when you drink while you're eating, that liquid, that's also part of the volume of what goes in your stomach. You have to think about that too. And a lot of people don't think about that.
That's right. And so, when I think of ways to minimize the nausea, number one, you'll also be more nauseated if you don't eat regularly.
Yes.
So, yep. So getting on that, use timers if you have to stay on track with your food, have Siri remind you, whatever it takes to stay on a good track with your food intake, and that will minimize the nausea. The other thing is, as you said, Andrea, avoiding gulping fluids at the same time that you're eating solids. Mm-hmm. So try to space out your fluid intake between meals so that it's not a lot during the meals, because it's true. A lot of what the medication does is it increases that sensitivity that kicks in with the stretch receptors of the stomach. So once your stomach is expanding, especially with water, like a lot of water consumption during meals, it will create more side effects. It'll definitely accentuate it.
Yeah.
Mm-hmm. But the other thing, go ahead.
Yeah, I was going to say, so you drink like sort of in between the meals a lot more, like time it out.
Right. And, one of the big issues is how people dose these things. That feeds into the nausea and side effect profile as well.
Yeah, I wanted to ask you about that, Dr. Cooper, because Marissa's original question is how do you maximize the benefits of GLP-1? And I know from, all the conversations and years that we've spent together that you see these GLP-1s as one tool in a very large toolbox when it comes to controlling and regulating and trying to normalize a person's metabolism. How do doctors who aren't super steeped in metabolic medicine, how do they decide what dose to give?
Well, if you follow the manufacturer's guidelines, they come out as though every single person is the same and that it should be dosed exactly the same way in every person. It should be at this starting dose, ramp up at this frequency by this much until you get to X dose, and you should stay on that dose even through maintenance. In real life, that is just, we don't really practice that type of medicine. Doctors look at their patients more as individuals, and no two patients are the same. And so we run into problems really because insurance companies, they want you to follow those guidelines. Otherwise, they might not approve the medication. So they might start out approving it. And if you find out your patient doesn't require a higher dose, they could literally stop covering it because you did not increase it. So there's all kinds of problems going on, again, as we always mention, with the insurance interference in medicine. But the proper way is to look at the metabolic picture of your patient to really figure out which medication would be the right one instead of just a shotgun approach or throwing a dart, in the air. But that's a little bit difficult, for doctors to do a thorough metabolic evaluation in a normal clinic situation because it takes a lot of extra time and also sometimes extra lab work, things that are difficult to then interpret and go back. And as I said, this isn't really taught in med school, but there are doctors out there that probably have more experience. But in any case, the starting doses and the ramp ups that the pharmaceutical companies recommend are not appropriate for everyone. Sometimes we start much lower than those starting doses and we ramp up much slower because the jumps can be very big between one dose and the next. And so if we have the benefit of like multi-dose pens where you can dial the dose in a little bit more in these micro dosing options, that's really good for people who are sensitive to medication. So I think erring on the side of slower ramp ups and not going all the way up the way that the drug companies are recommending is more beneficial in the long term for patients, because you may have a patient who responds at a very low dose, like really well. And why would you increase the medication dose if they're responding at that dose? Because if you increase it, you're getting into a territory where they may have more side effects than they should. You also may impair their nutritional state by influencing their appetite too much and inhibiting it more than you need to. And so that may be harder for them to get that food in that you need them to get. So it should be very individual. And most patients, as I'm sure Andrea will attest to, they think, and a lot of it's because their doctors aren't guiding them any differently. They think that the goal is to lose weight like super fast, the most amount of weight you possibly can, as fast as you possibly can. And that's not scientific. So in our clinic, we look at a patient's weight trajectory. So before we even start the medication, if we have a new patient, we do an intake, record their weight, they do their labs. By the time we're ready to go over their labs, it's been a period of time has gone by, and we're documenting their weight trajectory. Is their weight starting out stable? Is their weight increasing? And if so, at what pace is it increasing? is it decreasing? And if so, at what pace? So we get their baseline understanding, because you may have patients that are gaining weight at rapid rates because they're in that diet backlash mode, which is why I called my book The Metabolic Storm, because it is like a storm. It's just out of control dysregulation of the metabolic system after extreme diets, and the body just really wanting to get that weight back up and then some after these diets. And so we record that weight trajectory because that gives you a sense of that person's situation. And so that guides you a little bit too as to what you would need to do to help halt that. It's like a moving freight train. How do you stop that, stabilize, and get to a point where we're no longer going up, it's normalizing and coming down. And so if you can talk to the patients about that, then they can appreciate that sometimes it's great if they're just stabilizing as the first goal. They don't have to rapidly lose weight for it to be successful if they were gaining rapidly. So these are all things to take into consideration and to record those paces and see where we are just methodically, and have each practitioner should have in their mind what parameters they would use that would dictate whether they should increase or not. And it has to do with more than just your weight, obviously. It's going to have to do with your health condition. Are you on the verge of diabetes? Are you dealing with extreme cardiovascular risk? Do you have diabetic kidney disease? What else is going on? And that would also influence how you want to really dose these things. So it should be much more individual than what these labels are really dictating.
Well, I think some of the difference is the way you treat patients is for long-term health. And for sometimes this drug is being used for short-term weight loss. And that's very different way of prescribing a drug, and very different ways of using a drug.
Yeah.
So I think that that's some of the confusion in the way people talk about it too.
So we're just about at time. I'd love to hit one more thing briefly, Dr. Cooper, and that is, I've been seeing videos online on social media now where people are making the assertion that the weight loss that happens with these GLP-1 drugs are that people are losing muscle mass and not fat. Do we have any good science, any good studies that show where that weight loss is coming from?
There are good studies. They're not as good as I'd like to see because most of the people are still on diets on these studies. But it's really no different than on a diet. If you go on to a calorie-restricted diet, especially a carb-restricted, you're going to lose muscle mass and lean mass because you have to burn fuel from somewhere. And you can't build muscle or retain muscle without adequate fueling. So the impact of the GLP-1 on the body composition there's not this situation of lean mass loss. It's much more body fat loss. And in our patients, because we don't let them be on a diet, we're we're enforcing this regular eating, and we check lab work to make sure that they are nourished and everything. And then we have to set more goals if they're not, send them to the dietitian to make sure they're eating enough. But because we do that, it's very rare for us to see anyone with any significant lean mass loss. And in fact, a lot of patients that start with excess lean mass because of insulin, high insulin causes excess lean mass, they'll end up with normal lean mass. And the patients who start with normal lean mass end up with normal lean mass. Patients who start with low lean mass, we're trying to get that lean mass up anyway because it's due to other issues. So no, it's not the GLP-1s that would cause that. It would be more diets that are doing that.
All right, awesome. Okay, as we wrap it up, Andrea, any takeaways from you?
I think like anything, there's always going to be a few side effects, like anything, but the drugs are amazing.
Yeah, and they are one part of this total health regimen. I think you stated that so beautifully, Andrea, that we need to look at this as what is our health, not what does the scale say. And, I've stopped getting on the scale at my house, and I should probably just throw it away at some point because, Dr. Cooper, you're right. That doesn't really do any good, because if it's up a few pounds one day and down a few pounds the next day, it doesn't really it doesn't really matter. Dr. Cooper, what's your takeaway from this? This is our 4th episode of talking about the meds, but gosh, everybody's talking about this stuff now.
Well, I think putting it into this bigger context is really what we really have to focus on, and just understanding that these meds, they're not weight loss or appetite suppressing meds. They're meds that strengthen our metabolism in various ways, but they have a hard time doing that if we're not fueled, because underfueling weakens our metabolism. So in order for them to do their best, we need to take care of our metabolism from multiple directions, including avoiding calorie restrictive diets.
All right. Awesome. Marissa, thanks for the email. And if you have a question or a show suggestion, just get a hold of us. We'd love to hear from you. So this has been another edition of Fat Science with Dr. Emily Cooper and Andrea Taylor.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.